Good day, everyone. Today's topic is Priapism, which is a urological emergency characterized by a persistent penile erection lasting longer than 4 hours, not related to sexual arousal or desire. Prompt recognition and management are crucial to prevent long term complications such as erectile dysfunction. And I am your instructor, Dr. Muhammad Junaid Pachwa. Priapism is defined as a prolonged penile erection lasting more than 4 hours, which is not associated with sexual stimulation. It results from a failure of the normal mechanisms that regulate detumescence, leading to persistent engorgement of the corpora cavernosa. Though uncommon, priapism can occur in males of all ages with peak incidence between 20 and 50 years. It is particularly frequent in patients with hematologic diseases like sickle cell disease and leukemia, where blood viscosity or cellular abnormalities predispose to venous obstruction. How to classify priapism? Priapism is classified into three types. Ischemic or low flow priapism is the most common and a true emergency. Second type is non ischemic or high flow priapism resulting from unregulated arterial inflow, often occurs after trauma. And third type is a stuttering priapism, which refers to recurrent self limited episodes commonly seen in sickle cell disease. Pathophysiology of ischemic priapism. In ischemic priapism, there is venous outflow obstruction leading to blood stasis and hypoxia within the corpora cavernosa. As time progresses, acidosis and ischemia develops, resulting in cellular necrosis of smooth muscle tissue. After 24 hours, irreversible damage and fibrosis begin. In non-ischemic priapism, usually following blunt perineal trauma, an arteriocavernosal fistula develops, allowing continuous arterial inflow into the cavernosa. The erection is typically less rigid and non-painful, and the condition is not an emergency. The causes of priapism are diverse. Hematologic disorders like sickle cell anemia and leukemia are leading causes. Several medications such as phosphodiesterase 5 inhibitors, antidepressants, and intracavernosal agents can also induce priapism. About half of all cases remain idiopathic. Clinically, ischemic priapism presents with a painful, rigid erection of the corpora cavernosa while the glans remains soft. In contrast, non-ischemic priapism is usually painless, with a partially rigid penis, often following trauma. Duration beyond 4 hours warrants immediate evaluation. Diagnosis begins with a thorough history and examination. Cavernosal blood gas analysis confirms the type. Ischemic priapism shows hypoxia, hypercapnia, and acidosis, while non ischemic priapism displays normal oxygenation. Color Doppler ultrasound helps to visualize blood flow and possible arteriovenous fistula. The management depends on the type of priapism. Ischemic priapism is a surgical emergency requiring rapid intervention to restore detumescence, while non ischemic priapism may resolve spontaneously and often requires conservative treatment or targeted embolization. The primary goals are to relieve erection, preserve erectile function, and prevent recurrence. Stepwise management of ischemic priapism starts with pain control, hydration, and oxygenation, particularly in sickle cell patients. Cavernosal aspiration followed by intracavernosal injection of phenylephrine is the first line treatment. If these fail, surgical shunting may be required to establish drainage. In refractory cases, early penile prosthesis placement is considered. There are two types of surgical shunts which are used for ischemic priapism, which includes distal shunts and proximal shunts. And goal of these shunts is to re-establish venous outflow. When pharmacologic treatment fails, these surgical shunts are created between the corpora cavernosa and the glans or other venous structures. Distal shunts like the Winter and Algorab are commonly used first. Proximal shunts are reserved for persistent cases. Management of non-ischemic priapism includes conservative management generally since it rarely causes tissue ischemia. Measures include local compression and cold application. If persistent selective arterial embolization under angiography can close the fistula and restore normal function. How to manage priapism in sickle cell disease? In patients with sickle cell disease, management focuses on hydration, oxygenation, and analgesia to reduce sickling. Exchange transfusion may be necessary in severe cases. Preventive measures such as daily low dose phosphodiesterase 5 inhibitors and hydroxyurea can reduce the recurrence. Complications arising from priapism includes permanent erectile dysfunction and fibrosis of the corpora cavernosa. Penile deformity and psychological issues are also potential long term consequences, highlighting the urgency of prompt intervention. The prognosis is time dependent. In ischemic priapism, erections lasting over 24 hours often result in irreversible tissue damage and erectile dysfunction. While non ischemic priapism, however, has an excellent prognosis, especially with conservative management. To summarize, priapism is a prolonged erection lasting over 4 hours, unrelated to the sexual stimulation. Differentiating ischemic type from non ischemic type is essential. Ischemic priapism is a medical emergency which requires immediate aspiration, and phenylephrine injections are the life and organ saving steps. So that's it from today's lecture. Hope to see you in upcoming lectures. Thank you very much for listening to me very attentively.